to Innovators Corner. We're very excited to have you join us today. And today we have Jim Higgins from the Curtis National Hand Center joining us. So Dr. Higgins is an internationally recognized innovator in and reconstructive microsurgery. His development and popularization of the medial femoral trochlear or MFT flap for reconstruction of scaphoid nonunion and Kienbock's disease have really transformed the way that we approach these problems in the carpus. Dr. Higgins serves as chief of the Curtis National Hand Center in Baltimore, Maryland. He completed medical school and plastic surgery residency at the University of Rochester, followed by a hand surgery fellowship at the Curtis National Hand Center. His clinical and research interests include vascularized bone and cartilage reconstruction of extremity non-unions, functioning muscle reconstruction of the upper limb, toe transfer for digital reconstruction, complex reconstruction of upper extremity trauma, and vaso-occlusive disease of the hand. Dr. Higgins is an active member of multiple professional societies, serving on executive council and administrative committees for the ASSH, AHS, ASRM, and ABPS. He has served as program chair of the national meetings of the ASRM and ASSH. In addition, Dr. Higgins has been granted traveling fellowships and awards by national societies. He was the 2010 Marco Godina Traveling Fellow by the American Society of Reconstructive Microsurgery, the 2010 Visiting Professor for the American Society for the Surgery of the Hand, the 2013 to 2014 Sterling Burnell Traveling Fellow for the ASSH, the 2024 Zamboni Traveling Professor for the ASRM. In addition, he was awarded the 2024 Whelan Medal by the ASSH. So, Jim, thank you again so much for joining us today at the Innovators Corner of the Journal of Hand Surgery. So let's start off with a question about how did you first come up with the idea of the MFT flap for treatment of scaphoid non-union and Kienbock's disease?
Well, first of all, I'll just say I'm super pleased to be here and I appreciate the invite. To a degree, talking about innovation, you feel hesitant doing it because it would imply that you feel as if you've pushed the needle forward without help of a ton of other people. And I think I've done uh, my part, but certainly it has been a progression, particularly in the field of vascularized bone grafting, of a ton of different innovators that we all know. And these are surgeons in our field that we're all familiar with that have moved this subfield forward. To say, how did I come up with the idea? Now that would be not almost embarrassing for me to even say it because uh, this whole field of vascularized transfer of cartilage, which from a microsurgical standpoint is sort of a novel free tissue transfer. We've forever had free muscle transfers, free skin transfers, free toe transfers, even functioning muscles, and more fancy operations such as vascularized nerve transfers. But the actual transfer of bone and cartilage is relatively novel. However, that field really, for me, has become such an important part of my clinical and research career now that it's really usurped most of my time. Like literally, my clinic is primarily Kienbock's disease and scaphoid non-unions, which is the majority of what we're talking about. But the only reason that came to pass is because of collaboration. And not to make this a monologue, Harvey, I'm sorry if I'm doing that, but if
No,
I
it's
look
great.
if I look back and I say, how did this happen to you? And I think there's a lot of our colleagues around the country that some of the world's greatest brachial plexus surgeons didn't imagine they would be brachial plexus surgeons. Some of the world's, foremost congenital surgeons thought they were going to be adult surgeons when they started, but things sort of happen in your career that are fortuitous. And for me, it was born out of travel. And you had mentioned in your super generous introduction that indeed I've done a few traveling fellowships, and I always urge our fellows, and I will shout this from the mountaintops, but there's nothing better than taking a break from the trauma and the day in, day out rigor of starting a practice or trying to maintain a practice than getting on a plane or a train and going to visit someone else who you look up to and having that time in the airplane with cocktail napkins or whatever else and saying, you know what? I'm not just going there to figure out how to do trigger fingers. I'm going there to figure out how can we evaluate problem A or problem B from a different angle? What does this surgeon have that is novel that I can use as sort of dry kindling for my thinking? And for me, for sure, as everyone knows, and I do my best to really give credit to my close friend and colleague and just really incredible inspirational surgeon that is Heinz Berger. So Heinz, for those of you that know him, um, know of his creativity and his work ethic. If you don't know him, he is an amazing and super talented microsurgeon who lives in southern Austria in a town called Klagenfurt and works as a solo practitioner, um, but has an amazing lifestyle as a sort of roaming microsurgeon throughout Europe. Heinz and I grew to know one another, having been put at the podium in various and sundry international meetings. The very first time I met him actually was at a wrist meeting at Mayo, and I was put on a um, I was put on a panel with him, and I thought to myself, wait a minute, this guy is doing a lot of the stuff I'm doing. Like, what? He's got some amazing ideas. So pulled him aside, and if you've ever met him, you would recognize him as being one of the friendliest and most collaborative people you'll ever come across. So a fast friendship was struck, and I then was fortunate enough to have the opportunity to do the traveling fellowship with the American Society of Reconstructive Microsurgery, which you mentioned, which is the Marco Godina Traveling Fellowship, and that was basically a huge turning point for me. I spent most of my time, although I visited multiple places, but I spent most of my time in Austria. And how that story goes was that the idea, and this is where I'm getting to, is the idea originally was Heinz's. This is how it went. That was a period in the early 2000s when um, the medial femoral condyle vascularized cortical cancellous flap was novel. So it was published as a free flap for scaphoid reconstruction in 2001. And I recall that was the beginning of my fellowship, and a lot of people were saying, now, free flap for a scaphoid, now that is a step too far. Like that's crazy talk. This bone's only the size of a peanut. No one's going to do a free flap for that. And having come from Kazutura Doi, who's a magician, a lot of people would say, well, that's the that is the playground of magicians like Dr. Doi, but it's not something that's for the rest of us. But then, if you think about it, lo and behold, here we are, 2026. You know, you'd say that's a short period of time, 25 years later, for this to be like an in-service question, right? Or an oral boards question, like what is the pedicle of the descending judicular or the medial femoral condyle flap? So it's now commonplace. I dare say someone would roll their eyes if I said that, but I think it's certainly commonly offered around the globe in specialty centers. So Heinz and I were both focusing our careers at that time, first decade of 2000, on really utilizing vascularized cortical periosteal flaps and medial femoral condyle. And then there was a case in 2000, in the early 2000s, I think it was 2008, he had a patient who was an electrician who he was doing an MFC, cortical cancellous MFC for scaphoid reconstruction. And in the middle of the case, realized that the proximal pole was too small for him to salvage. Imagine that. You're in a case, you have this patient's knee open. You then say, uh-oh, we use the word non-salvageable proximal pole now like it's part of the decision tree, right? But back then it wasn't like a term. But he said, "Oh my gosh, this proximal pole is non-salvageable." And I wish he was here to tell this story, and he would do it more justice than I would. But he then decided he was just going to roam up into the joint and go look for cartilage. He said, "At this point, I am just going to detonate the proximal pole, and I'm going to see if I can find a piece of cartilage that can rebuild it." So talk about an audible. I mean, that's a huge audible. You're in the patient's asleep, harvest the medial femoral trochlea, what we now refer to as the MFT, and that patient did amazingly well. Now, he published that in the German literature, in the equivalent of what's the Journal of Trauma for German-speaking countries. And I knew of that case report and I visited him and I actually interviewed and examined that electrician, and he did do unbelievably well. Like great range of motion. He healed gangbusters. And I recall at that time thinking to myself, and I used to say to my fellows, if you do something for the first time, and it goes well, it's tempting to say, man, I am just awesome. The alternative though is, and I think the healthy alternative is to say, and wait a minute, did I just get lucky? And Heinz, to his credit, was like, I'm not sure. Maybe I got lucky. So this guy did great, but he and I talked about it a lot, and we discussed like, what the possibilities are? Should we repeat that? Maybe this has got great potential for the future. And while I was there during the Marco Godina ASRM, American Society of Reconstructive Microsurgery Traveling Fellowship, the week was ending when I was supposed to head home, and a surgeon, a general surgeon from Germany, called Heinz and said, and I was standing next to him, he said, "Hi, I'm a general surgeon from Germany. I read your article, your case report. I have a two-time failed scaphoid nonunion of the proximal pole. I'm an avid mountain biker, an ice hockey player. I would like to come to you to have my proximal pole removed and reconstructed with the trochlea." This was like Thursday. So Heinz, I'm sure the patient was anticipating him thinking like, okay, why don't you come down and we'll talk about it, and then you go back home and maybe we'll set this up for a few months. And Heinz said, "Do you think you could get here by Saturday?" So, so the patient and he held a lengthy conversation. This guy was a surgeon, was medically, very capable of understanding informed consent, etc., and holding a medical conversation. So next thing you know, like Saturday rolls around and we're doing it first case in the morning. So the second scaphoid non-union, and this point we're not calling audible. We are going straight into his joint to find the same piece that Heinz found and basically design it. No cadavers, no, certainly no computer assisted design. You're going in there to go build a scaphoid. And that patient did unbelievably well. And I've subsequently interviewed and examined him on multiple occasions. In fact, famously pictures of of us playing hockey together and mountain biking together. Very active guy. So super happy. But again, did we get lucky or are we just amazing? Right? It's better to
Yeah.
say maybe we
Mhm.
get lucky. So I think that's what led to all of the investigation and then the comfort level with saying maybe we should repeat this now. In our practice here in Baltimore, we've done over 120 scaphoids and now subsequently used it for lunates and harvested this bone flap and cartilage flap over 200 times. So, and Heinz, I mean, you take that number and maybe double it. So the idea was the brainchild of an intraoperative decision-making call that was super creative by Heinsberger, not by me. I've had a lot, I'd like to think, of influence on it based on our laboratory work and also the many, many times over beers that Heinz and I have talked about. How can we do this? What's a safer way? What's the better approach? Can we apply this to other problems? But that's how it evolved. It was like 2009, 10.
So, that's a really amazing story. And I think you bring up a really important point about innovation because very often innovation is accidental. And I think, you really have to travel to meet people to learn to innovate. I have a story to add as well. So, for those of us in plastic surgery, we know Bob Allen, who invented the deep flap. And there's a story about Bob Allen that was actually told to me about how he invented the PAP flap, the profound artery perforator flap for breast
Mhm.
reconstruction. So apparently he was doing a gracilis flap in a live surgery course and it didn't go as planned. So he spontaneously did the first free pap flap for breast reconstruction and it worked out great. So I think this is probably more common than we think it actually is. Um, but
Absolutely.
again, yeah.
Yeah, I mean, you know, uh, emergency situations or unanticipated curveballs are like that is the fire starter for brand new innovative ideas. And Heinz definitely came up with this one, and we have definitely run with that ball now since, you figure it's been another 16 years now, and it's, you know, osteochondral transfer has really evolved a lot since then. And we've a lot more donor sites, a lot more applications, and it's really been a team effort. I mean, part of that really is a story. It puts a smile on my face as I have right now, not because um, it has definitely ignited a field of interest for me and has usurped a lot of my practice. And now at this whatever this period is of my practice, maybe you could call it the distal one third, um, has definitely become the area of concentration, right?
Yeah.
So that's a big gift. But I think maybe the bigger gift was, this really amazing friendship over years and years of collaboration. And we've been back and forth over the Atlantic. In fact, I'm going over there in 2 weeks to one more time, do a little more surgery and a little more skiing. But it's really been something that's made the job more than a job, and this is what we all look for.
Yeah, absolutely. I think it's a really good excuse to travel as well.
Hmm.
So what was the standard of care for treatment of scaphoid non-union and Kienbock's disease when you first started doing these procedures?
Well, I think the super compelling data on MFC for waist non-unions um, has now, in my practice, become the standard maneuver for a waist non-union. But this is super debatable, and this is a hot topic for sure at our national meetings. Scaphoid non-union ICLs and symposia. I mean, those things fill up because everyone's got their opinions, and I don't know if free microvascular transfer of bone or bone and cartilage is the answer. I mean, certainly I'm super curious about the success shown with arthroscopic management.
Mhm.
Certainly, wouldn't that be if like 10 years from now it became quite clear that there's no reason to do anything other than arthroscopically? People would look back and say, like, man, you know, Heinz Berger and Jim Higgins were like incredibly overly aggressive back in like the 2020s. Uh, but it may be that arthroscopy can supplant this. I would say prior to the use of um, free tissue transfer, certainly for waist level non-unions, vascularized bone grafting was available. I think those pedicled vascularized flaps, so the 1-2 ICS ray and the methylene flap, as it's so called, the volar distal radius bone flap, they're, I would argue, much harder to do. Like the pedicle has got a limited range of a reach. It's very difficult to inset them and get the screw right where you want it. I think clearly for me, those cases are harder. And I know that people will roll their eyes when you say that, but if you've done them both, you would uh, agree with, I believe, with what I'm saying. So, but I think the question is for proximal poles, non-salvageable proximal poles, the standard of care was a salvage operation, right? So
Yeah.
you've got this, unfortunately, almost entirely, 20-something-year-old male population. A recent survey of like 170 scaphoid non-unions that I recently did, like it was overwhelmingly young men who are in sort of clearly wage earning years, at the height of their sort of athletic engagement, or perhaps just after the height of their athletic engagement. But they have a problem that what we had to offer them was scaphoid excision and carpal fusion or proximal carpectomy, both of which are fraught with a lot of disadvantages, not the least of which is diminished grip strength, but also, range of motion and risk of post surgical arthritis and risk of revision surgery in the future. So I think that this was for scaphoids, for example. And we've just really talked about scaphoids, but we could also talk about lunates and capitates. I think it really has moved the needle forward in terms of giving these patients a prospect for carpal preservation. I'd like to say durable reconstruction, and that's TBD, right?
Mhm.
And that is that the burden of understanding this fully is on the shoulders of us, is on the shoulders of surgeons doing this. We need to not just say, hey, we're doing something pretty cool and perhaps some would accuse it of being like overly sexy, but with something that we need to do due diligence in terms of long-term follow-up. Like, does this have a role for the future of young men, young patients with unsalvageable or non-salvageable proximal goals going forward? Like, what is the role of this in the history of hand surgery globally? So that's on us. And I have strong opinions about that, Harvey, and I'm sorry about making it wrong, but I really think if you are an innovator, I'm not calling myself an innovator, but if you are doing something that is novel, you are absolutely obligated to follow up, even if the follow-up is negative. And if the follow-up's negative, like, look, this blew up. It was a disaster. Everybody, had revision surgery. I applaud that paper. It should be written, and people need to know, should we redirect our gaze elsewhere or should we continue to work on this? Those are just as valuable as successful follow-up um, contributions.
So again, very important points. Like you, Jim, I like doing the sexy operations as well, but it's so true that you really need to get data to support what you're doing.
For sure.
Um, yeah. So can you tell us a little bit about what barriers that you face in the initial stages of popularizing the MFT flap? Did people say you're crazy? How did you get through those barriers to try and convince people that this is the right thing to do?
Yeah, I love the verbs you use there because I'd love to comment on all of them. Um, to popularize or convince, those are the two words I want to focus on. I think I've done a lot of introspection about this, and I don't want to paint myself as feeling as if I'm the sole purveyor of this new idea. There are many great surgeons around the country doing this, and Heinz is certainly doing more than I am. But if you were to look introspectively at how this is progressing and what your role is in it, big or small, I think it's important to, number one, make sure that you don't feel as if success is you doing an operation that succeeds, right? If we did this operation, if Heinz and I and others around the country did this operation and it turned out it blew up and we reported and said, look, this didn't work, good on you. I mean, I call that like good investigative reporting. It made sense at the time, but we explored it. It didn't work out, and now we decided to change our tactics. But we can't if we start to feel as if like this is going to be a legacy move, or this is going to be a feather in one's cap, or a trademark operation that if it succeeds, boy, that'll be looked upon favorably. That's a massive trap, right? I mean, it's a huge trap.
Yeah.
So you have to say to yourself, look, man, this is not, your name's not attached to this. There's no, you know, uh, secondary gain. So I think, just a constant reasserting that it's important for honest reporting. So I don't think it's your job to convince anyone or to popularize something. If you think that it's working and the data shows that it's working, it should, right? It should become more
Mhm.
mainstream. I think the burden might be maybe better um, thought of is the burden might be like, well, if it is successful, you know, other people would want to know how to do it. So how can you train other folks to do that? And I think um, myself and Heinz and other surgeons around the country that are doing this, Alex Shin and Steve Moran and um, uh, Scott Levin, I'm sure receive a lot of emails saying, "Hey, can I come and watch a case or two or three?" And even one and two and three makes me a little bit nervous. Like this operation I watched and did a bunch of them in Europe with Heinz, and we each at least had each other to hang on to, you know, before feeling comfortable, like just sort of solo one, and that you got it, that I can do the carpentry well. And I don't want to overly dramatize it. It's just that the thing with this operation, and you think of any technology, right? Any new procedure, any new approach, uh, you've got to say to yourself, well, the ease of it being widespread, um, embraced or adapted, in a widespread fashion, is all related to either the technical difficulty or the risk. With this particular operation, it's the leg. Right. It's not like
Yeah.
I don't know how to put a screw in a scaphoid. No one, no, all of us are like, "Wait, look, I got that." We all know how to do microsurgical anastomosis. No one's like, "Oh my gosh, how do we hook up those blood vessels?" Yeah, it's the leg. It's all about the leg. How do you get in and out of a 20-something-year-old's leg that didn't hurt at all
Mhm.
before the surgery? That's the threshold, right? And that's where you've got to get comfortable with. And I think, how can you get in and out with the smallest incision, the most minimal retraction, the just harvest of enough bone and cartilage you need, no extra. You don't want to be throwing away a lot of cartilage. And um, have that patient return to sport, return to play. These are all patients that are involved in sports. They're all in the gym. They're all lifting. A lot of them are squatting. They want to be playing cutting sports like basketball. So that's the thing, right? How do you get in and out of the leg
Mhm.
penalty free? And that requires reps, and not just reps in the OR. I think it requires reps in the OR and then seeing those patients in the office and saying, okay, I
Mhm.
actually believe it. Like I saw that guy get back to biking competitively. I saw this patient go back to his college basketball team. That's that's where the security is. It's not, can I operate a sagittal saw, right? So
Yeah.
so I always wonder about that, and I think the best way to do that is a fellowship. Only in a fellowship do you have a full year
Mhm.
to drink in that experience, follow those patients longitudinally. And so that's what we're trying to do. I hear we, you know, we have now, as I said, we've done 120 of these scaphoids and 85 lunates, and a lot of these, it's increasing in frequency. So in recent years, you know, there's an MFT really basically on every Tuesday here. So the fellows, I do feel like they get reps and reps and reps and reps and the reps and then again, and they're seeing the patients in the office. So they're not just reading an article and saying, am I confident with that surgeon's reporting?
Mhm.
So uh, I have a lot of friends that come and visit, and I applaud that because that's what I do with Heinz, and it puts a smile on my face. But it's tough. I think it's tough to get totally comfortable with it. Takes time. If it was like, look, we're doing imagine the first time a single portal endoscopic carpal tunnel release came out, you probably could go there and
Oh
watch
yeah.
it, right? And be like, all right, I
Yeah.
got it.
Yeah.
That's a different story. So everything's got its particular or peculiar hurdles. So I think that's the obligation, is trying to figure out how to provide training for those interested, not how to convince or how to make the world provide this service in a widespread fashion. You know what I mean? I think
Yeah.
that's the way of looking at it.
No, definitely. So that brings me to my next question. So early on, how was your conversation like with patients when you're trying to convince them to do an MFT? Because I mean, you could consider an experimental procedure at that point in time. So what were those conversations like?
Yeah. I'm gonna call you out on that convince word again. So I really go to great lengths. These are lengthy consults, right? Because it's not quick. I think a scaphoid nonunion is a difficult consult because you got to let the folks know that your son or you don't have a health problem. This is a bone that's a pesky problem for us. It's a recognized high risk of nonunion. The last surgery you had was a perfect surgery, just didn't work. And by the way, we're seeing that all year long. So we now have a large amount of telehealth for this problem because this is now something that has a catchment nationally. And, um, for me, I've embraced telehealth as an opening consult for folks that are from afar and may want to travel. And our telehealth, for me, my telehealth annually are about 120 telehealth visits per year. That's a lot for, I think, a hand surgeon. But those visits are, 45 minutes to an hour, so that's a lot of time. And the reason it's so long is I insist that they don't make a decision the first day. I send them all the articles after we have the discussion, and I review for them the alternatives, and I go through the data about the outcomes of PRC or four corner fusion. And I have little pre-written synopses of various articles on outcomes of those in terms of range of motion, group strength, etc. But I do try to, again, remind myself that it's not my job to convince the patient to do the MFT, but it's my job. And I think, as I've said to my fellows, the surgery is not the hard part. The hard part is figuring out for that patient with that newborn, with that manual labor job, with that, you know, wife and kids, but no family in the area to help them, or with with their, degree of discomfort or lack of discomfort, or maybe they're in a competitive sport or even a professional athlete. There's plenty of patients out there that, and I harp on this with our fellows, there's loads of scaphoid non-unions that we're watching. Like, why don't you go continue to play professional sports, make hay while the sun shines, and when all that's over, we'll rebuild you. Like all of these decisions about when and does this risk benefit analysis fit this patient? Um, that's something that's the art of it. I don't claim to be great at it, but I really try to be pretty conservative about it. So, in as much as I say, we've done a lot of scaphoids, there's as many of those that we're not doing, or we're doing some other procedure for. We're offering cancellous bone grafting in hopes to be minimally invasive and see if we can succeed, or watching the scaphoid non-union, electing to do nothing, or offering a salvage operation. So I think that's the trickiest part of it for sure. Recently, uh, we've published a few papers. I'm particularly proud of this one that I published with Harvey W, my partner and our research director, on the risk factors of scaphoid non-union failure. And this really goes into how we analyze each patient individually with regard to their surgical risk factors to try to really look at each scaphoid individually as having particular risk factors and try to use that as a way of making a decision. Should we go all the way to MFT? Because MFT really, it's sort of the nuclear option. I mean,
Yeah.
you
Mm.
can't get more invasive. That's not inarguable. So
Yeah.
you got to make sure that you need it.
Yeah. Yeah. So, you've done a lot of MFTs now. So can you tell us a little bit about how your surgical technique has evolved over time?
Yeah, so for sure. Earlier you mentioned pressures. I think in the very beginning, I really wanted to make sure that we were delivering vascularized bone,
Mhm.
right? So I thought, oh, this is a great idea, but maybe it's all just talk. I need to make sure that we're actually delivering the benefits of vascularized bone. And for that reason, believe it or not, and this would make some people just say this is crazy, I would do these MFT flops with skin paddles.
Okay.
like with a cutaneous component. Imagine you come in with your 18-year-old son. He's got a recurrent scaphoid onion, and I said, I'm going to take a bone and cartilage out of your knee. I'm going to do a free flop. There's going to be a microscope. I'm going to connect small blood vessels. And they're already a little bit like, should I have come to Baltimore? And then I say, on top of that, I'm going to take a piece of skin that's with it. I'm going to put it on the back of your wrist. You're going to stay in the hospital for 5 days. The nurses are going to come in with a Doppler. They're going to be listening for the Doppler signal. If it stops, if this Doppler signal stops, we are going to emergently take your son back to the operating room. And then I'm showing them an x-ray and there's a little bone the size of a peanut. And they're looking at me like, oh my God, are you kidding me? So, but I was so hell-bent and so purist about this in the beginning because I had to be sure that we were actually delivering vascularized bone. So we did that. We did that, Harvey, for a long time. We did osteochondral cutaneous flaps. And then after proving that we did not have a lot of take backs, in fact, I only had one take back in the first, I think, 25, my partners were saying to me, look, this is ridiculous. Like
Mhm.
you're never, and at national meetings, people were like, no one's going to take on like the 5-day admission for a scaphoid non-union. So I said, all right, I'm going to fly blind. We're going to take the skin off of this thing. We're just going to put this cartilage in. And I say flying blind, meaning literally, we don't know if and as a plastic surgeon, as you know, that's a very uncomfortable feeling. Like
Mhm.
we don't know after I close the skin what happened. So that's what we do now. So we moved from that, that's years and years and years ago. I moved to overnight stay. They go home the next day. There's no Doppler monitoring. For a while, I was putting in implantable buried venous Dopplers.
Mhm.
And then I stopped doing that. I said, look, you're getting what you get. And now it's overnight. I've done a few of them outpatient for either social or insurance reasons. It's doable, it's totally doable. But most of them stay overnight. So that was one. Number two, the approach. I have fiddled with trying to make the morphology of the bone better and better, how to do the carpentry better and better. And I've used the lateral trochlea on the outside of the
Mhm.
knee and used the medial side and thought about should I go to the radial artery in the volar form or in the snuff box, and all of that for me has settled into or now routine dorsal approach, anastomose in the snuff box, ipsilateral medial side harvest.
Mhm.
That's my sort of like blue plate, boom, 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 knock those out. Because it works well, it's reproducible, I can do it in a sort of um, protocolized fat. The OR is ready for it. They know what, the nurses all know, and the team all knows, and the nurse on the floor, that technique is where we settled. But there was a bit of fiddling around for sure for a while.
Yeah, obviously, yeah. But it sounds like you've reached your comfortable point, your comfort zone, which is great.
Yeah.
So you talk a little bit about the LFT. So I think a lot of our listeners would be curious as to what are your current indications for the LFT as opposed to the MFT.
Yeah. So the LFT is actually a lot closer to the skin, so you can get down on the LFT in a hurry. And it is a donor site. If you say to yourself, like, why are we even comfortable with this idea as hand surgeons? Of course, we always look to predicate surgeries. Like in one of the predicate operations is an oats, and the oats is harvested medially or laterally, commonly laterally. Now you might say, like, well, it's not really like an oats. An oats is taken like you're taking a dowel out. You're cutting out the edge of the
Mhm.
trochlea. And I will say I'm very aware of that, and I'm very concerned about the outcome of these knees over time. And we're following them with, I'm super proud of our research group's work and how organized they are and how they're prospectively following these patients and doing outcomes measures over time. But I do worry more about the laterals than the medials. And the
Mhm.
reason is logical. It's not empirical, it's logical. I would say as we all know, the patella rises laterally as you flex your knee. Our sports colleagues have shown very clearly that the amount of pressure on the lateral trochlea is higher than that on the medial trochlea because of this physiologic reality. And so I don't like going laterally if I can avoid it. So when can I not avoid it? And for me, the clear indications for going laterally is to rebuild the capitate. And this is a not often encountered problem, but capitate AVN, capitate fracture nonunion, or traumatic injuries of the capitate in very young patients. I published a series of those patients, and there's not a ton, and it's some single digit number that I've done. Maybe it's like 6. But if you were to study the morphology of these bones, as we focus on this incredibly in our lab, is trying to make the bones about the same shape on the sagittal and
Hmm.
coronal planes as the bones that we're rebuilding. The MFT is very similar to the proximal scaphoid and proximal lunate on the coronal plane. It's less similar, but still acceptably similar on the sagittal plane. If you were to look at the capitate on the sagittal plane, it's much more like the LFT.
I see.
And this is why that's my go-to for the capitate. So that's one reason. And it's a dorsal approach, as you'd imagine. And it does a really nice job of replacing the proximal capitate. And so you can preserve a mid-carpal joint on a patient, particularly if it's compelling, if they're like 20, 25.
Hmm.
The other time I would use the LFT is if I had a patient that needed a scaphoid rebuilt or lunate rebuilt, and their ipsilateral medial trochlea I felt was compromised, meaning they had an ACL reconstruction, collateral ligament injury in the past, some sort of fracture work in the past. Those patients, I'll try to stay away from that previously injured knee because I have been in on those knees and I found the vascular harvest is harder.
Hmm.
And you don't need to make anything harder. So I'll go to the opposite knee. But if you're approaching dorsally, geometrically, and this is, I could describe this on a piece of paper, but if you were going to the contralateral knee and you want the vessels to drape dorsally to the radial artery, it's better to go to the lateral side,
Hmm.
particularly for the scaphoid. It's a big difference.
Right.
So that's the other reason I would do it. I'd say at a distant third, and this is total esoterica here, but the talus. So if you have AV under your talus, and it's typically a very sort of more of like a 90-degree angle slope on the mortise. Um, this is much more like the LFT than the MFT. Um, that doesn't occur very frequently, but those would be really my if it was a total jump ball and the knee was both knees were available, I would absolutely go to the medial side every time I could.
Hmm.
Yeah.
Yeah, absolutely. So you talk a little bit about your research team, and the projects they're working on. Could you tell
Mhm.
us a little bit about how your research has come over the years and what are your current research efforts and projects you're working on?
Yeah, so for this in particular, I think, as I mentioned, I do really feel like it's absolutely on us to follow up on this, and,
Hmm.
and and it would be a disservice to us, to these patients, to future patients, and to other centers, not to get overly dramatic, but to just not ever report on. I mean, there are operations out there that I wonder, like, what happened to that operation, like the Rassel screw, like what happened?
Oh yeah, yeah,
What happened to that? Those patients are still out there. I want to know. Like if it
yeah,
didn't work, I want to know. If it worked, I
yeah.
want to know.
Of course.
But not to just bash on the rational, but I think that if it works or doesn't work, either way, it has to be reported. So we're following all of those patients now, these 200 and some patients, prospectively with preoperative examinations, patient-related outcomes measures, and post-operatively. And we recently have just eclipsed a decade of good follow-up,
Mhm.
both radiographic and PROMs. Super valuable, right? And it
Yeah.
turned out great. And I was happy that it turned out great. not taking ownership on it, right? Don't have too much of a dog in the fight, but I was happy for the patients that it turned out great. But you figure these patients, if you're 20, their runway is like 70 years, right? So
Mhm.
how are you doing in 10 years? Maybe that's not enough. And I wonder what people would think. I think JBJS would love of us to show them 50-year follow-up, you know? So
50-year follow-up is so difficult. I think it's impossible.
but the more the better, right? So I
Yeah.
think if we show 20-year follow-up or 25-year follow-up, it'll be great, great contribution. So we're following all those patients prospectively. That's number one for sure. Number two, I think what I really want to know is how do those young patients prospectively do versus a prospectively collected cohort of salvage operations, right? This is the question.
Mhm.
You got our super small proximal pole and you've had two screws placed in it before. Should you bother having your trochlear or should you just go get the PRC or the four corner fusion? So we're trying to collect those. Now we have fewer patients, right, that have four corners and pure. So that's a slow collection process. But boy, what a statement. What a
Mhm.
statement, right? Prospective collection of just young patients over time. I'd be so proud of that if we ever, well, when we get that paper out. So I would say that's really the big goal. The other sort of cool side projects that we're working on is, from the donor side morbidity of the knee. Like this is a big question, right? The knee, what if
Mhm.
the knee? Like, oh my gosh, you're not even a knee surgeon, you're operating the knee. So we can collect PROMs, and the PROMs we've used, Harvey, have been like PROMs that knee surgeons use. Like they're using them like for ACLs, use them for like collaterals, use them for like knee arthritis. And you might be like, well, that's not your problem. Like that's not a PRM that's designed for a PRM that's designed for MFT harvest, right?
Mhm.
So I thought to myself, like, wouldn't it be great if there's something like irrefutable? Like just like what other than going to one of these guys' houses and talking to him about his knee and going to watch him play sports, like what would convince you otherwise? And I think functional outcomes. So we have in our hand center an incredible motion lab. One of those motion labs that has sensors that can be put on every limb, on every joint, and record uh, motion in real time as patients are ambulating, as they're running. They even have now with this new lab that's at our center, the ability to have them walk on a treadmill with irregular surfaces
Mhm.
and irregular speeds and visual, as they say, perturbations, meaning you're almost trying to trip the patient and see how does their quadriceps mechanism, their patellofemoral alignment, their leg stability fare under these adverse conditions. That is great data. I'm super excited about that. I think if we could show that there's really, even in an adverse conditions, no effect on gait, that'd be better than me saying, hey, look, Harvey, just trust me.
Mhm.
There's something called the, ABCD score that the knee surgeons are using, and he got an 89. I mean, what do you know about an 89 and an ABCD score, right? You don't have no
Yeah.
idea. So I think that our motion lab is going to be an important part of our follow-up. The other thing is I'm working quite a bit on figuring out are there alternatives, particularly for recently Kienbock's. So one of my, and I know I'm going off a little on a tangent, but and there's other stuff like Dupuytren's that I have a lot of interest in as well. But um, in Kienbock's, as you know, we're using the osteochondral flaps for reconstructing lunates, and I'm super happy with how that's proceeding. And we've got, over 84, 85 patients, I think, recently. We'll follow them over time. But if you look at Kienbock's, it's much more difficult to study, right?
Mhm.
The outcomes, right? Like, what is the target? In scaphoids, the answer is like, what's your range of motion? What's your grip strength? Did it heal? Do you have arthritis? Simple.
Yep.
Kienbock's, you do a radial shortening osteotomy, the bone always looks horrible. For the
Mhm.
rest of your life, it looks horrible. Your range of motion never is normal.
Mhm.
And did we win or did we lose? Like, is that really, did that succeed or not? So defining success in Kienbock I find to be difficult. And I'm struggling with that even with MFTs. Is it MRI at 10 years? Is it is there some other way that I can show vitality of the bone that is more accurate than that? And what is the time interval? I'm also thinking that maybe if we look at the ways that we've tackled the Kienbock over the years, it's included unloading, which is to say radial shortening or capitate shortening, deletion, PRC, right? Revascularization, whether that be a 4 or 5 ECA or MFT,
Mhm.
whatever your preference is, or strict immobilization, right? So
Yeah.
casting. So recently it struck me, we have this dorsal spanning plate for the distal radius that we've now all grown super comfortable with it being really low morbidity, right? We all
Yeah.
thought, I mean,
Mhm.
tell me if I'm wrong here, but when that first came out, I said, there's no way these distal radius patients are going to get stiff as a board if you put that thing in there.
Mhm.
And Doug Hannell and others showed that it's remarkably well tolerated. And we all started using it and we all gained comfort with it and realized, wow, these patients do pretty well with this long plate across the wrist for a long time and distraction. So I said, maybe we should use that implant. And this is serendipitous, right? Maybe we should use that implant that we're now comfortable with to strictly immobilize,
Mhm.
parentheses, achieve the same effect as long-term casting, except this is the best cast in the world. You are not moving an iota. And you don't have to wear a plastic bag when you jump in the shower. So strict immobilization plus when I've been putting this in, I'm unloading the wrist. So I'll, insert the screws in the metacarpal and then distract at the radius
Mhm.
in the slotted hole and put the screw in so that essentially both the radiocarpal and midcarpal joint are distracted. So you're really unloading the lunate. So I started this protocol and we now have 21 patients that we've done this on, and they are all in the same duration. I've put it in for 4 months and taken it out. And thus far, none of these patients have needed another operation. Now that's like nice to say, but we only really have 2 years follow-up so far.
Mhm.
So what is the right amount of follow-up? And is not having another operation, is that the data point? Or is it MRI? Because those lunates are not going to look, they're never going to look normal, right? But
Yeah.
if I could say with confidence and publish, we have taken type 1, 2, and even type 3 lunates, put them in a super easy to use, widely familiar implant, dorsal distraction plating for 4 months where it's really no skin off the patient's, nose. They're using their hand routinely, taking it out of 4 months, and it will avoid all other interventions and it will basically quiet that episode of Kienbock. They will not progress any further and they'll be done for the rest of their life. I mean, that would be the answer. I would guesstimate that might even supplant, like, in terms of ease, it would supplant even this idea of metaphyseal core decompression. Like, people would say, I'm totally willing to put a distraction plate. I'll put them on all my patients.
Jim, that's a really fascinating idea. So how are you? So because obviously I know you love to do MFTs. So how are you choosing between patients who get MFT for Kienbock and those who are getting this dorsal spanning plate now?
Yeah. So at first, I started saying dorsal spanning plate for type or for stage 1 and stage 2. And of course,
Yeah.
when I say that, uh, I'm talking about non-collapsed, mostly non-fractured patients. So a minimal fracture that is non-displaced, I would still put the plate in.
Mhm.
For patients that have particularly a displaced coronal fracture, which is a commonplace fracture that encountered in Kienbock, those patients I would say you need an MFT. There's no point in trying to distract your lunate. This is going to cause you pain.
Mhm.
By the way, that's a lot of supposition, right? And a lot of my guesswork. but that's where I have sort of landed. It's true though, and you wonder, looking back, I always ponder this. If the patients don't have a distracted, displaced coronal plane fracture,
Mhm.
the MFT would be a lot easier, right?
Yes.
And they'd
Yeah.
probably do a lot better, right? So
Yeah.
you're removing these sort of low-hanging fruit from the MFT group, and you're putting them in the distraction plating group and just loading up the MFTs with all these super hard cases. So I wonder, like, gosh, am I screwing up the data?
So you're actually reducing the number of patients in your series, right, that you're collecting over time now.
Yeah, I think yeah, and for some of
Yeah.
those patients, I'll have
Yeah.
a telehealth, and I'll say, look,
Yeah.
listen, you got to be comfortable with me sort of. I'm making up this operation with this distraction plate. I don't
Mhm.
know if it works, but it makes sense. It's less invasive. I'm not going to open your knee joint. You will need a second operation. I don't have enough data yet. I'm hopeful it makes sense logically. Are you on board? And
Mhm.
for many patients, particularly if there's a parent in the room, like we're on the Zoom, and this patient's 17,
Mhm.
that spanning plate sounded pretty good,
Of course. Yeah.
you know? But I definitely don't talk them into it. I expose my own ignorance about what I know, what I don't know, and there's more that I don't know that I do know. And we all do this with patients. Try your best to provide them informed consent. We'll never actually reach truly informed consent for anything, but I try and get close. And that's what I'm doing right now with these spanning plates is ones
Mhm.
and twos and like minimally fractured threes.
Okay.
Yeah. Yeah.
So that's an evolution in your practice as well, right? Over
Yeah.
time.
And listen, if three Bs with coronal splits, you know, were cured by distraction plating, I would be happy to never open anyone's knee again. Like that would be amazing. It'd be I wonder, it's something like that. Like, the first time that people use the vac, think about the vac, right? Imagine
Yeah.
I always love playing with my fellows and say, like, let's play the game of you were there first. Someone in your boardroom said, you know what we should do is put a sponge on this thing and suck on it for a few weeks. Like you'd be like, what?
It sounds crazy. It still does sound crazy.
Right? But then it works like unbelievably well.
Yeah.
And you're like, wow, I'm glad we tried that. What if what
Mhm.
if we were just like, no, that's really stupid. So I don't know, maybe I'm hopeful about the spanning plate and I'll see, but the way to figure it out is to prospectively and I'd like to brag about the research that quote I'm doing, but it's all got to do with our research team here at the Hand Center in Baltimore,
Mhm.
and that's driven by Abhijit Ladi and also Ken Means, our research director and our clinical research consultant. Those two guys are amazing and run a huge team. I mean, there's like all sorts of fellows and biostatisticians and editors and a huge team of folks that are doing it right, and they keep me out of it.
Mhm.
Like those patients they would talk to my patient ahead of me, and like I'm not supposed to be in the room. They follow up with them. They're like, I'm not supposed to be on the call. So all that stuff is kept nice and clean, and they're doing it right. So huge kudos to their work, and that they're making this move forward in a way that I'm proud of.
Well, so I'm really looking forward to seeing those results when you publish them.
Yeah, me too.
Yeah. So innovation is difficult, as obviously, you have shared with us tonight. So what lessons have you learned in your innovation journey?
Well, I think something we've touched on, I think making sure, always checking yourself and making sure you're not taking ownership of it or personal pride in its success or failure. Understanding that a negative outcome is well worth reporting. But if there's something I pass on to my fellows for sure, it's just looking back and not to call myself an old man, but looking back at my career and saying, hey, what were the things that went right, that led me to getting so much energy and enthusiasm about this particular topic? Because I think everyone would like to be in the midst of something that's developing.
Hmm.
whether it be minor or major. That's if you feel like something is evolving and not static, that's what's going to make your career longevity
Yeah.
what it ought to be. The way to stumble upon these novel things, I think, is I guess you could be a genius, but most of us aren't. The way to really do it is collaboration. And these experiences traveling, it doesn't have, you can travel to the next town, you can travel around the globe, but um, I always tell our fellows, I know you look at these traveling fellowships and you say, my gosh, the Benel, there's no way I could do the Benel traveling fellowship. And I'm glad that both of us are on this conversation here because
Yeah.
like everyone's qualified. Like
Yeah, absolutely.
just
Yeah.
get in line. I mean, there shouldn't be this oh, that's restricted for some other people in some echelon. Just get in line. If you've got a good idea, get in line. And by the way, if you get it, great. It's going to change your career.
Hmm.
If you don't get it, you should just go make your own.
Yeah.
And most of us around the globe, I would say, love getting a phone call saying, "Hey, can I come visit you?"
Hmm.
Or I've got a cool idea. I think what you're doing is something like I'm doing. I'd love to come to your place and exchange ideas. Um, people are going the answer is going to be yes. Like you shouldn't be sitting there wringing your hands wondering like, oh my gosh, is he or she going to be angry or I don't know, uninviting. The vast majority of people around the globe are going to be happy that you asked. They may be honored or excited to have a guest come, and it's going to be as beneficial for them as for you. And that period of just putting the brakes on, getting on the airplane, working on the cocktail napkin, as I've said, and try to rewire problems. It's going to stimulate, even if you go on that visit and you're like, man, I didn't come up with one idea. You just gotta keep doing it because you will. It's not that you're not creative, or I mean, Lord knows I'm not creative. So it's not that you're not creative. It's just like the clinical scenario's got to come down the pipe. The light bulb's got to go off. And so anyway, I guess I'm making a plug for fellowships, and there's a lot out there other than the Benel Fellowship is. We all know our own society offers the Benel Fellowship and also the Gelberman Fellowship, but there's a number of different traveling fellowships for the American Society of Reconstructive Microsurgery as a Gadina traveling fellowship, and also the AOA's got a lot of traveling fellowships.
Hmm.
Um, there's even the British Society has a traveling fellowship, and these fellowships are different flavors and different formats. Some of them are like, congratulations, get in a bus. You're going to go around with 4 or 5 other people, and we're going to show you to the places we want you to see. That's got some benefit. What I love about the Gadina, Benel, Gelberman is you know, what do you want to see? You tell the society, look, I'm super interested in thoracic outlet syndrome.
Yeah.
Like, they're not going to tell you where to go, Harvey. You know where the best and the smartest and the brightest are. So you design your own thing. And they're like, man, we need someone to move this field forward. So Harvey Chim, you're up. Let's go see. And so that gives you the ability you can tap into people that no one's ever heard of, you know?
Hmm.
You go into to the rock stars that everyone's visiting, and then you go to other places that maybe a friend of yours told you about that is sort of a little bit undiscovered. And anyway, those travels are the makings of innovation, and they are the things that's going to keep your career young, and you're going to come back with fire. And I have a junior partner, Val Shubenetz. He's an incredible replant surgeon, incredible. And I know you know him, Harvey.
Yeah.
And he's
Yeah.
a
He's great.
good mutual
Yeah.
friend, but
Yeah.
he's in the early stages of his career. But early in his career, we encouraged him is like you know, go visit other surgeons. This was the topic he wanted.
Yeah.
So I suggested he visit Dong Chul Lee.
Mhm.
who, if you know Dr. Lee, he's incredibly dynamic.
Oh,
You know,
he is. It's so fun to visit as well. Yeah.
great speaker. Yeah, great.
Yeah.
It's a great visit, right?
Yeah, it's.
So Val went and he visited Dong and he came home and he was like on fire. I mean, this guy was just had so much fire in his belly. He was like he wanted to put everything back on. And
Yeah.
toe transfers, toe pulps, he still has it. And he's that single visit. I'm sure that's the one most influential thing that's occurred in his career so far. And that's just that's a single visit. Imagine, I mean, if you were to make surgical travel and education a routine part of your career, how much could blossom from those types of experiences?
I totally agree with you, Jim. I feel that every few years I have to kind of take a reset and just travel around the world and learn new things from people, and it helps me refocus better on my practice. And to what you said about, anybody really can get the Bernal Fellowship or the Galberman or the Godina. Almost didn't think that I would get the Bernal Fellowship, and honestly, it was a bit of a surprise that I got it. So, I mean, I think if we can get it, anybody can get it.
Right. And I think it should be on the merit of your field of interest, right? And how
Yeah.
much you've delved into it. And I've sat on a lot of those selection committees at time for various selections, and you see those proposals, and I think the proposals that are most compelling are the ones that are yes, novel, but well thought out, and the society feels like, wow, this is gonna move the ball forward for us. This is
Yeah.
gonna
Yeah.
help us innovate. And so if you've got a great idea, get out there and shout about it. You don't have to wait until your name is like super recognizable by everybody.
Yeah.
Just
I
get in
still
line.
agree.
Yeah.
So this was really amazing and really inspirational, Jim. My last question for you is, what advice would you have for young surgeons trying to innovate like yourself?
Yeah, I think keep your mind open.
Mhm.
Travel, as I said, and keep your mind open though to how to attack problems that you see as maybe you went through your fellowship and for example, scaphoid nonunions. Like, well, I learned how to do the 1-2 ICS array and the Mafflin, and those are, or maybe just I learned Cancel's bone grafting and 1-2 ICS array, and those are tool A and tool B, and I'm going to apply those to every single case. If you're going to a meeting and you're hearing about arthroscopic bone grafting for scaphoid nonunions,
Mhm.
you gotta you gotta explore that. I mean, don't decide that you've got an arrow in your quiver for every problem and you're done. Otherwise, your career is going to be over before you know it. So, open mind, obviously, most important, and visiting for innovation, and obviously also if you do stumble upon a field where you think you can move the needle forward, make sure that right out of the gates, when you start doing it, try to be organized, try to collect your information in a prospective manner and not years later be like, gosh, I wish I had collected this information appropriately so I can report it. Um, those are, I would say, the big keys, be a good investigator, be an open-minded surgeon, and be a collaborative global surgeon. Those would probably be my three big pieces of advice.
That was fantastic. So, well, thank you so much, Jim, for joining us tonight on Innovators Corner. And on behalf of the editorial team at the Journal of Hand Surgery, we'd like to thank you all for listening into Innovators Corner. Thank you so much, everybody.